This conference will now be recorded.
Welcome to the EMQ series, and now it is a gynecology session 1. Welcome. Okay, so 28-year-old woman for cytology has been reported as a low grade dyskaryosis. So, what will be the next step? Single most next appropriate step.
Psych HPV.
Yes.
Ma'am, this is
Yes, HPV.
ma'am. This is as per the old guidelines.
New guideline also HPV. New guideline also HPV. Primary HPV testing improved sensitivity, high negative predictive value, decreases incidence of cancer. Apart from this, yeah, so new guideline and old guide. New guideline uh, the guideline came in 2020, and recently few updates are there, but almost the guideline not too much of changes there. Okay, so here patient came routine recall cytology. It was reported as borderline, and HPV test was done, that was inadequate. So what will be the next step?
Repeat after 3 months.
Yes, it is repeat after 3 months. So if the inadequate results are there, either with this HPV or cytology, you have to repeat after 3 months. And if there are two consecutive HPV cytology inadequate, then the colposcopy referral. Inadequate cytology sample at 24 month, then also colposcopy referral. Now, the patient for routine cytology has low grade HPV triage that was inadequate. So again, same, it is a same question. HPV was inadequate.
Repeat in 3 months.
Yes. So HPV, it will not be cytology. It will be repeat. It has to be, answer has to be repeat in 3 months. It is not cytology. Repeat after 3 months. Here also repeat after 3 months. So they will be repeating like HPV only. Okay. So again, next appropriate step. So 25-year-old woman has a cytology 1 week ago. It is low grade and HPV triage. HPV has come as positive. So what should be the next step?
Colposcopy.
Yes, refer to the colposcopy. Now this uh, this is the new chart. This is a new chart from the that has come, and this chart HPV positive, cytology abnormal. So in our question, HPV positive, cytology abnormal. So HPV, if the HPV test is done and cytology, then the cytology test is done. If the cytology is abnormal, then refer to colposcopy. Okay, refer to colposcopy. So if you go to the previous guideline or if we come to the new guideline, this flow chart is from the new updated flow chart. But the answer is HPV positive and cytology abnormal is the colposcopy. Okay, so here again, uh, single most next management. So they want next step. 60-year-old woman in the clinic after TBS for low pain. She has a unilocular ovarian cyst of this dimension. She's asymptomatic. So what should be done?
P, repeat after 4 to 6 months.
Mm, so post-menopause, you are speaking from the
Oh,
guideline.
sorry. I thought premenopause. Yes,
Mm,
yes. We will do CA 125 and calculate RMI score.
yes. So answer is measurement of CA125. So this is from your guideline. It is recommended that ovarian cyst in postmenopausal women should be initially assessed by the CA125 and TVS scan. Okay, so postmenopausal women in cytology in the gynecology clinic referred by GP is suggestive of irritable bowel syndrome, and she has a family history of cancer, and her mother died 8 years ago. So what should be done next?
CA 125, measure CA 125. I
Why?
50 years above a history of irritable bowel syndrome. Many symptoms suggestive of irritable bowel syndrome.
But there is no ultrasound given that shows there is a mass. Any ultrasound is there?
No.
No. Ultrasound is not there. So why you will do C125? So she is presenting with a irritable bowel syndrome. Doesn't mean that she has got ovarian cyst or mass. It could be only irritable bowel only. So what you will do first? What you will do?
Refer to gynae MDT.
You are in gynecology. You are seeing patient in the gynecology clinic, referred by GP already. What you will do next step?
History and examination.
Yes, at least examine the patient first. So once you will examine the patient, then only you'll be able to assess that what investigations are required. Okay. So appropriate tests to be carried out in the woman with a postmenopausal symptom who developed irritable bowel syndrome in last 12 months, over 50 years of age, with a significant history of ovarian bowel and breast cancer. Physical examination include BMI, PA to detect ascites, MMX, and vaginal examination. So this is the answer.
Hmm.
So ultrasound, a 60-year-old postmenopausal woman, and she has got new vague symptom. CA125 is 365 complex mass with a ascites in the pelvis. What you will do?
Uh, uh, we'll do CT scan.
Yes, you will do CT scan. So if a clinical picture, USG and the markers, malignant disease suspected, you will do CT scan of abdomen and pelvis. And onward after that, refer to the gynae oncology team, MDT.
Hmm.
So this is the same thing. If you calculate the RMI
Hmm.
also, then also it will be more than 200. Then also the answer
Hmm.
will be scan abdomen pelvis. So the GP ultrasound scan arranged by GP 1 year ago, it demonstrated 40 cyst. Patient remained asymptomatic. Reassurance done after 12 months. Cyst remains unchanged. So two ultrasound has been done. What you will do?
Uh, measure CA 125. No, sorry. Uh, s- s- I'm confused. या तो CA 125 or like since this size is unchanged, can reassure and discharge. I'm confused between the two.
So, if the cyst is less than in postmenopausal woman, cyst is less than 5 centimeter, and conservative management, then a scan is done. Now, 2 times scan done. After that, if it is unchanged, then this would be the answer. Repeat assessment in another 4 to 6 months.
P.
Okay. Yes. So the 37-year-old woman with a suprapubic and vaginal pain of 6 month duration, she complained of aches and sensation of voiding. Voiding relieves her pain. Aggravated by stress, acids, beverage, sexual intercourse. On examination, there is a leukocyte nitrites protein culture negative. So what you will think?
Um, cystoscopy. D option cystoscopy. Bladder Peak syndrome.
Bladder pain syndrome. Why you will do cystoscopy?
To exclude other causes.
But before that, many things are there. The protein plus and nitrite plus. What does it mean? Infection is there.
In fact, but culture is saying it's negative, so I thought ki will not do that.
So this is the answer. This is direct from the guideline. Because urine culture for
Mm.
urine and chlamydia. So urine tested to rule out UTI as a prerequisite for the diagnosis of BPS. Investigation of urinary uroplasma chlamydia to be considered in symptomatic patient with negative cultures and pyuria. Okay.
Mm. Mm-hmm. Yes, ma'am.
So the patient with the history of painful micturition, vague pain in suprapubic area, she wakes up several times, feels that she's stressed out, found tenderness in suprapubic area anterior vaginal wall. Blood is 3 plus, leukocyte, specimen sent for culture that is negative.
Yeah, urine cytology. Okay.
Cytology, better answer? Oh, yeah, cytology only. So cytology is the answer because 3 plus blood suggestive of possibility of malignancy. So patient is visiting with the diagnosis of BPS and also symptom of SUI failed to which are due to BPS failed to respond to treatment. What you will do?
Urodynamics.
Yes, ideally, that should be the answer. Urodynamics, because diagnosis patient is not responding. That means there is a trouble with the diagnosis. So, 59-year-old woman with a postmenopausal bleeding. Now, TVS shows irregular endometrium 3.5. What you will do?
Reassurance.
How you can reassure with irregular endometrium?
Oh, no. 3.5 mm, I thought. Oh, people biopsy. People endometrial biopsy.
People or TVS? People or hysteroscopy and biopsy. Okay. So, yeah, because of the irregular endometrium, though less than 4 endometrium is sort of a reassuring, but here because they wrote irregular, because of that, good idea, not missing on anything, just go to that. So this is from the BGCS guideline, uh, endometrial cancer. So hysteroscopy is recommended if outpatient biopsy by other means is not feasible, or for the patient who has ultrasound irregularities. So our patient, what we
Mm.
did, has irregularity. Okay. It should be offered as an OPD procedure, first line of investigation for those endometrial thickness more than 4 mm. Okay. Now, a 32-year-old woman with a spotting, a 62-year-old woman with spotting, and there is no abnormality. Local examination has been done. TBS shows double layer thickness of 3.7.
Uh, well, Piper's biopsy.
Yes, people is an exam. See, postmenopausal most common cause of bleeding would be atrophy, but
Atrophic. Hmm.
they have already done the clinical examination, so that means it is the endometrial cause only. Endometrium,
Hmm.
though it is 3.4, but the lining is
7.
regular. Right, lining is regular, double layered.
Hmm.
The question is not correct because how double layer can be 3.7? It has to be more. Double layer endometrium we cannot see in postmenopausal. It happens in ovulating women. But
Hmm.
this question is wrong only because double layer cannot happen in 62. Okay, but yeah,
Hmm.
as the like in on other words, as the USG is fine, there is no irregularity or anything. So consideration for people.
Hmm.
Okay. So yeah, this part this is again from the BGCS guideline. The patient with HMB are not ET more than 4 mm. OPD endometrial biopsy should be carried out. 60-year-old woman postmenopausal biopsy, postmenopausal spotting for 2 months because of cervical polyp. Polyp is protruding from cervix. You sent it for the histological examination, but it was not cervical, it was endometrial polyp with hyperplasia. So, what you will do?
Hysteroscopy and biopsy.
Ideally, this should be the answer hysteroscopy. Diagnosis of endometrial hyperplasia requires histopathological endometrial tissue sampling. Diagnostic histoscopy should be considered to facilitate or obtain endometrial sample. Okay. Here again, there is a postmenopausal bleeding. TBS shows small uterus and endometrial polyp. It should be hysteroscopy only, hysteroscopy and biopsy.
Hmm.
Okay, single most effective form of HRT. 39-year-old
Hmm.
woman with premature ovarian failure with symptoms of amenorrhea, hot flashes, night sweats, and loss of libido.
HRT or combined estrogen. E.
HRT is the answer. So, what is the HRT given in POI? 17 beta estradiol is preferred as compared to ethinylestrol or equine estrogen and macronized natural progesterone.
Hmm.
So 651-year-old woman 6 months ago, low mood and intermittent anxiety. Otherwise, she is well, not on any medication. She is having low mood.
CBT. Low mood and anxiety.
Yes, CBT. So psychological symptoms. So a CBT to elevate a low mood anxiety that rise out of menopause. So, a 49-year-old woman has abdominal hysterectomy. She has vasomotor symptom of hot flashes, night sweats, lack of interest in sex, low mood.
Estrogen only HRT. F.
Hmm. So it should be estrogen replacement. So F should be the answer. So this helps in finding out where what type of HRT is given. If the perimenopausal woman, a continuous estrogen progesterone or cyclical progesterone has to be given. Hysterectomized women, estrogen. Subtotal hysterectomy, estrogen, if no endometrium. Then endometrial ablation, cyclical or CCT, and early menopause, high estrogen. So according to the situation given, you know, this will help you in identifying which HRT is given to which person. So 59-year-old woman, 56-year-old woman with low sexual desire. She's even on common estrogen progesterone HRT for the last 3 years.
Mm. Option G. My next option is testosterone.
Option what?
G. Only that contains testosterone.
Hmm. Yes. So consider testosterone supplementation for the menopausal woman with low sexual desire. If HRT alone is not effective. This is from NICE. Now, 50-year-old woman on tamoxifen. She had cancer 3 years back. Failed to respond to cognitive, failed to respond to the cognitive behavior therapy.
SNRI. J.
What?
SNRI. J. J.
Why J? Clonidine?
Because she's on tamoxifen.
हाँ तो tamoxifen SNRI cannot be given. So answer would be clonidine because SSRI, antidepressant, paroxetine. Basically, there had been a interaction at this enzyme. Okay, and why not SNRI? See this. So SNRI with tamoxifen, paroxetine, fluoxetine, bupropion, they should be avoided. Moderate inhibitors are duloxetine, sertraline, citalopram, and doxepin, and weak are venlafaxine. Their use is not restricted by tamoxifen. So this you can use, but SNRI, what you were saying, what SNRI you were saying? You're saying just SNRI. So all these cannot be used.
Okay.
So patient with HMV, heavy periods, 30 days, prolonged significant dysmenorrhea. She had a vaginal delivery, uterus bulky, USG and FBC has been done.
N6. Mm.
The patient is having what?
Heavy bleeding with significant dysmenorrhea.
So dysmenorrhea, what he will give? NSAIDs.
NSAIDs.
So the patient has HMB. Her hemoglobin is 10. Multiple small fibroids. She is not hypertensive or not dysmenorrhea. You are requesting a scan again.
Hmm. Um, and ulipristal acetate.
Ulipristal acetate.
And because hemoglobin is specifically mentioned, 100 gram per liter.
Okay, so uh, but before giving ulipristal, we have to at least should have a scan.
Okay.
Scan is not there. So just give her
Okay.
symptomatic treatment. It is not confirmed case. Ultrasound of 37-year presented with HMV, hemoglobin 102. The ultrasound shows fibroid measuring 5 centimeters.
And now it's a ulipristal acetate. Because you can't give LNGIUs.
Yes, now it could be ulipristal. And this is the update from the new from the NICE guideline. This is if the fibroid is less than 3 centimeter, or then in this situations like LNGIUS is the first one.
Hmm.
Okay. Now here pharmacological treatment is needed, Trenexa and CID, or patient is treated with a vilipristal acetate. So two courses are given, 5 milligram up to 4 courses, and fibroid size more than 3 centimeter. So we are discussing the fibroid that is 5 centimeter. 40-year-old woman sterilized, returned for follow-up. She has heavy periods for 2 years. She dedicates to continue and bleed heavily. Scan shows adenomyosis.
Endometrial ablation.
Endometrial ablation will not help with the see in endometrial ablation what is done? Endometrial lining it is removed.
Hmm.
It is removed. Okay, so endometrial lining, removing endometrial lining, adenomyosis there will be no help because in adenomyosis endometrium is growing inside the muscle of the uterus. So you
Hmm.
have to make that endometrium working less. Then only the patient will get relief, and that can a local action is there only with the marina foil. Okay.
Ma'am, but here it's written, ma'am, but here it is written she has written for follow-up after having been on various pharmaceutical treatments. And she has
Oh,
received therapy.
yeah. pharmaceutical treatment, actually they didn't tell us what she told, what they have given. Maybe oral tablets.
Oh, okay.
They didn't specify that. But looking at
Mm-hmm.
endometriosis and sterilization and 40 years and heavy periods, these are the keyword you will consider LNGIUS. Okay, horrible question these are. Are you able to see so many
Yes,
options?
ma'am, I'm able to see.
So many options.
But
So to be,
I
this
need
is,
some time.
uh-huh, no issue. You take your time. Uh,
23.
so, but 23-year-old woman on COC missed one pill.
Hmm. Ma'am, U, option U.
Yes. So it is if the one missed pill is there, um, 48 hours to less than 72 hours. Okay. After
Hmm.
there is a change in the guideline. So I put this. So if the patient has taken 1 week continuous and she missed the pill for 48 hours to less than 3 days, then she should take the pill immediate, continue same, and no additional contraception is required. Okay.
Hmm.
So 19-year-old woman uses patch and
Hmm.
noticed patch displays for 24 hour ago. Patch less than 24 hours displaced.
F.
Okay, so F is your reapply the patch, but you will not reapply the same patch. You will apply the new
New
patch.
patch.
Neck rest remains the same, no additional contraception. Now this is from the new guideline. Patch detachment less than 48 hours. Then if there had been correct 7 days of use, attach new patch. Keep new patch till scheduled removal, no additional contraception. So patient is on CHC and patch has been dislodged for 36 to 48 hours. So answer is still same
Same. Same. Yeah.
because the new guideline, it is the recommendation is for less than 48 hours.
Potato.
Yes. So the patient is on CHC. She applied patch 3 days ago, has fallen off. It was his first patch having unprotected intercourse.
Mm. I. Okay.
Here the patch,
Mm.
uh, patch
Oh.
detachment more than 48 hours. Okay. So here
Hmm.
said I start new patch additional. hormonal contraception needed for first 7 days. But this is the answer. C. J.
Emergency contraception.
New patch. uh, EC, because she has had sex also. So,
Mm-hmm.
so answer will be attach new patch. Keep new patch until the scheduled removal day. Additional contraception 7 days, and uh, follow pregnancy test. Okay.
Yes, ma'am.
Okay. So 31-year-old presented with a abdominal pain, irregular bleeding. Pregnancy test is positive. Left ectopic pregnancy. Some fluids in the pelvis. On counseling, she opted for surgery. Self-ingotomy has been done. So, what will be the single most useful step in the management?
Hmm.
Now, the self-ingotomy has been done. How you will follow you up?
Ma'am, K. Option K.
Sure. Basically, they have not given the correct answer. So, if the self-ingotomy has been done, then HCG measurement has to be done weekly after 1 week and weekly after till negative. So that option is not there.
Hmm.
Weekly after 1 week and weekly. Okay.
Okay.
So correct answer is HCG measurement after 1 week, uh, repeating weekly till it becomes negative. So 30-year-old woman with onset of pain and amenorrhea for 6 weeks, UPT positive, right ectopic pregnancy to 1.5 to 2 centimeter, beta HCG 1500. She opts for methotrexate and methotrexate has been given. So what will be the next plan?
Ma'am, this is I option. Days 4 and 7th and week.
This is option I, because repeat beta HCG level on day 2, 4 and 7 after original test. 33-year-old woman with unruptured ectopic pregnancy opted for methotrexate. She was given IM injection. Beta HCG 4 and 7 days was done. It has fallen only by 10%. So less fall.
Hmm. We'll do TVS.
What? Yes,
We
TVS.
will.
Yes. If it is fall is less than 15, then repeat TVS, and once the TVS comes on, then they may or may not give methotrexate. So 19-year-old woman with lower abdominal pain, irregular bleeding, clinically stable, UPD positive, right ectopic pregnancy. She has been diagnosis and about to counsel about management. So what is the answer?
Beta HCG 48 hours later. Uh, uh,
But USG has confirmed ectopic pregnancy.
she's stable, madam.
So what you can give?
And we can give expected management, or you can do beta CG 2 days later and decide.
Basically, you have to do beta CG. Beta C they have not given.
My question is not given now.
Yes, so you have to arrange beta CG.
And option A.
Right now, no, it is 48 hours later. Today only you will do beta CG. With the report of
Okay.
beta CG, you can give the either expectant, medical, or surgical.
Okay. Okay.
In question, they have not provided us with the beta HCG. Without the value of
Hmm.
beta HCG, how would you manage?
Hmm.
So, patient with excessive vomiting at 8 weeks, first pregnancy, USG shows gestational sac with no pole and yolk sac. There's cystic areas in placenta and transverse to anterior to transverse. The diameter is 2.
This is partial,
Hmm.
but partial molar pregnancy is not there. Oh, incomplete molar pregnancy.
This would be partial mole. So there are certain. This is from the guideline. Partial molar pregnancy to be subtle. Reporting finding of multiple soft marker, including cystic spaces and placenta. Ratio of transverse to anterior posterior dimension of gestational sac is 1:1.5. This is the these features may help in diagnosis of partial molar pregnancy. So 22-year-old woman in early pregnancy suspense unit. She had snowstorm appearance.
Complete molar pregnancy. See.
Yes, very nice. This is snowstorm appearance. Answer is complete no. Incomplete miscarriage. Patient evacuation offered for RPUC. Examination shows trophoblastic tissue without any chorionic villi.
I no chorionic villi.
Mm-hmm.
C.
C is complete mole. Complete mole villi is there. Blood vascularity is not there.
Then I'm option I, PSTT, placenta cytoblastic tumor, no chorionic villi.
Oh God. Choriocarcinoma. In choriocarcinoma, the absence of chorionic villi. Okay.
Hmm.
So 26-year-old woman with failed pregnancy. Histopathology shows incomplete molar pregnancy. Registered with GTD center. Her levels shoot up to 10,000 over 4 weeks. What is the diagnosis?
Hmm. Hmm. Choriocarcinoma.
What is GTN?
GTN is choriocarcinoma.
GTN is a spectrum.
Oh,
It could be choriocarcinoma, it could be PSTT, it could be ESTT, it could be
okay.
anything. GTN is a wider diagnosis. All these are the like forms of GTN.
Okay, ma'am.
So now here the patient has got various procedures on vulva. 60-year-old woman presented with vulvar lesion soreness 3-month duration. She examined and found to have whitish area on vulva. Tissue taken interface in between a normal and abnormal epithelium large enough to diagnose uh, cancer. So what is the type of biopsy has been taken?
E-
What?
Which white standard excision?
See, read again. A tissue taken from interface. They're not excising. They're taking it from the uh, interface between a normal and abnormal area.
Incisional biopsy.
So yes, it is incisional biopsy. So incisional biopsy is the intent for securing diagnosis. Ideally, it contains interface between normal and abnormal epithelium.
Then what is the difference with white excision?
Yeah, come to the next question. So the patient has a localized area in the light labia majora, superficial lesion of 1 into 1 centimeter, no palpable nodes, and the malignant. The tissue removal does not provide a tumor-free margin of 1 centimeter surrounding whole area.
Excisional biopsy.
Excisional biopsy.
No tumor free zone.
Yes, when the abnormal epithelium has been taken out, that means there is complete excision, but the margins are not cleared. So now, uh, like there was a 2 centimeter lesion, and there is a pigmented swelling, no lymphadenopathy. Removed lesion is complete with 1 centimeter free margin all around. Answer:
Now, ma'am, standard excision.
here is the radical excision. There is a clearance of 1 centimeter whole area. So now you got difference between incisional, excisional, or radical
No,
biopsy.
ma'am. No, ma'am. I want N, ma'am. White standard excision. N option.
What you're saying N.
Yes,
Why?
ma'am. White standard excision.
Okay. Wide excision. I think the free margin should be 1.5 centimeter. Wide local excision, the free margin surrounding the lesion should be 1.5 centimeter.
Okay.
Okay. Yes. Okay. So here there is a hirsutism, single most endocrine pathology. So 43-year-old woman with a rapidly growing hirsutism complains of baldness, amenorrhea, weight gain. She has been investigation for infertility, ovulation induction with 10 year ago. Scan shows cyst, FSH is 5.7, LH is 7.6, and testosterone is 5.1. So the keyword is rapidly progressing, and the
Hmm.
testosterone 5.1.
5.1. L.
L is what? No, no, no.
Sertoli.
Adrenal tumor.
And here is not given, so I thought.
What?
And multiple cysts. Here is adrenal markers are not given, and multiple cysts in ovary, so I thought that. Okay, ma'am.
No, no.
Adrenal.
So the patient has got PCOS kind of picture.
Hmm. But testosterone is 5.1 and
Testosterone
rapidly developing.
is the answer. So if the mild hyperandrogenism with serum testosterone level around 2 to 5 nanomole, then the diagnosis would be PCOS. But if it is more than 5 nanomole, then it is androgen secreting tumor. Okay.
Hmm.
What? So, so see from the option single best investigation. 30-year woman investigated for fertility 2 years. Periods regular, semen analysis is fine. She suffers from dyspareunia, painful period, altered bowel habit, last 4 years. There is a her pelvis tender, bilateral and suspected induration on the right uterine ligaments.
Um, I diagnostic um, diagnostic laparoscopy and dye test.
Why you want to do dye test?
Now, ma'am, I wanted to diagnose. She has endometriosis.
Hmm.
So that laparoscopy required. Or
See, every
TVS.
yes, TVS. So, symptoms suggestive of endometriosis. So, first investigation will be TBS only. So, 29-year-old woman with irregular periods, BMI 27. She has weight increased, and GP diagnosed PCOS. He ordered some blood test that for her menstruation. Ultrasound shows uh, uh, and all blood test has been fine. Her partner's semen analysis is also fine. So what investigation is required?
AMH. No, sorry, ma'am. 21 day progesterone test.
What test?
Progesterone test to confirm ovulation. Q, irregular periods, Q.
Yes. If it is regular period, then to check ovulation, progesterone level check is done 21st day of cycle. But if it is irregular periods, then the ovulation check uh, can be done um, every 7 days uh, or every weekly until next period from 28 to 35 days. So 32-year-old woman with a partner of 5 years, they have two miscarriage. No, the two miscarriages are there. Periods regular, intercourse is fine, partner semen is also normal, and clinical examination is normal.
HSG. Mm. Ma'am,
This
ma'am,
question
can I
is,
ask?
yes,
Ma'am, here so saying she is conceiving, but there is miscarriage.
yes. Basically, this, see, like for either we do test for ovulation or tubes or semen. Here, semen test has been done. She had miscarriages. That means she is getting pregnant. No problem with the tubes. Periods are regular. They have already given. So
Mm.
basically, this answer for this patient should be wait and watch. Nothing is required for this woman. That the answer given in the book is she is having a regular period, so confirm ovulation by 21 days progesterone. Because wait and watch is not an answer question. Sorry,
Mm.
option.
Mm.
Because she has no problem, basically regular periods, normal semen, and she is getting pregnant. That is indirect clue that the tubes are open. So 4 year infertility history, the patient is listed for diagnostic lab. She gave history of cyclical pain, and she also has this is associated with deep dyspareunia. Uh, Pre-operative assessment has been done in the morning. You find that chlamydia screening has not been done.
Do it.
Hmm?
We'll do chlamydia screening and tubal tubal pattens. It is.
What should be the answer?
Ma'am, E.
E. See, you have to understand whenever the patient is going for intrauterine procedure, usually they will, if the patient is symptomatic, like the patient is showing symptoms of clinical infection or PID, that time they will treat the patient and
Hmm.
later on they will do the procedure. But here, patient has got no problem. Asymptomatic patient, but yeah, the screening has not been done. So what they will do, they will give her antibiotic and proceed with the instrumentation. A.
Like, okay.
There are two things happen. Either they will give antibiotics and proceed with the procedure. This will be prophylactic antibiotics, or they will take the screen and do the procedure. And once the result of screen comes, and if anything is positive, that time the antibiotics are given. Is it clear?
Hmm. Yes, ma'am.
52-year-old woman suggestive of overactive bladder. She has a diagnosis of AAB, offered to bladder training. Bladder training failed to give her result.
L.
L is,
Oxybutynin.
see, it is oxybutynin is not given that regular. It is, yeah, oxybutynin could be there. Oxybutynin, tolterodine, and derifenasin. Okay,
Hmm.
but if you see that T has got both
Better
bladder
option.
better option. So
Hmm.
tolterodine and bladder training. So the patient is fit, 76-year-old woman, 70-year-old woman. She has got symptoms of urgency frequency incontinence, mild prolapse and tear, unable to contract pelvic floor muscles. She can't contract. So if the patient cannot contract, answer item
G.
yes. Then a biofeedback or electrical stimulation. 57-year-old woman diagnosed with OAB treated with drugs but failed to make any difference. She offered botulinum toxin A, but she declined. She doesn't want Botox. What the next treatment?
V. Transcutaneous sacral nerve stimulation.
Yes. Transcutaneous. No, no, it is percutaneous. Percutaneous sacral nerve stimulation. Okay. So see, percutaneous sacral nerve stimulation after MDT review, if the symptoms are not responding to Botox of the patient does not want catheterization associated with Botox. So it is percutaneous sacral nerve stimulation. So 67-year-old woman with frequency urgency in urgent continence suffers from nocturia. She has lower abdominal mass, confirmed to be the bladder on the scan. Urine analysis, she has nitrates blood cell. She was given antibiotic and emptied bladder. She returned back with the same symptoms. What do you think? She's having what? Retention.
Hmm.
So,
I. Intermittent self-catheterization.
yes, ideally answer should be intermittent catheterization. So, here the 45-year-old woman with regular bleeding, she has a variance 6 cm 6 centimeter, papilla in the cyst, no ascites, C125 120 240, staging laparotomy, unilateral tuber with intact capsule. No, no secondaries on the surface. Peritoneal washings are negative. TH, BSO infracolectomy was done. Tumor was well defined. Serous cystadenocarcinoma. What could be the stage? Unilateral tumor, capsule intact.
1A. Oh, 1A.
Yes. So answer is 1A. So tumor limited to one ovary, capsule intact. So 50-year-old woman, large ovarian cyst, 10 into 7 centimeter, extended to tube, peritoneal washings done, THBSO, infracolic omentectomy done, peritoneal nodes are negative, histologically mucinous adenocarcinoma negative washings. So the clue is
2A. Extended to the fimble end of tube.
yes,
2A.
2AF, it is extended to the tube.
Tube.
Extension or implants on uterus or fallopian tubes or ovaries, then it is 2A. Okay. So any question?
No, ma'am.
Okay. Thank you for joining.